In this video, we'll discuss about cardiac marker. What is marker? These are the clinical laboratory tests which are used to detect a cardiac dysfunction. So, clinical laboratory tests which are used to detect cardiac dysfunction. These are known as cardiac marker. Ideal marker should be able to diagnose the disease early, that is earliest detection of myocardial injury. Then it should be specific and sensitive. Then it should be tell about the prognosis of cardiac disease. Then it should be helpful in monitoring the patient with cardiac disease and also monitoring the patient with cardiac surgery. So, what is the ideal marker able to diagnose earliest detection of disease, specific and sensitive, then prognosis of cardiac disease, then it should be monitoring. So these are the four important points for ideal marker. The cardiac disease which diagnosis with the help of cardiac markers are acute myocardial infarction and conjunctive cardiac failure. What are the two types of disease? Acute myocardial infarction and conjunctive cardiac failure. First, we want to look at acute myocardial infarction. It is due to atherosclerosis or coronary vasospasm or narrowing lumen of the coronary vasculature or narrow lumen of coronary vasculature. There is decreased blood supply to the heart that leads to damage or necrosis or ischemia of heart muscles. That is known as acute myocardial infarction due to blockade or vasospasm of coronary vasculature that leads to the damage, necrosis, ischemia of or that part of heart which is distal to the artery, that is known as acute myocardial infarction. What is conjunctive cardiac failure? CCF. Conjunctive cardiac failure, this one inability of heart to pump the blood out, that is called heart failure or ventricular failure, inability of heart to pump out the blood. There are number of markers which can useful to detection of acute myocardial infarction and conjunctive cardiac failure. Now, what are the indication for cardiac marker? First important one is symptoms, that is chest pain, ECG changes and history of heart disease. When the patient with a history of heart disease, it is important to cardiac investigation and cardiac marker. Then to the laboratory investigation, that is cardiac marker. So what are the three things important? Symptoms, chest pain, then ECG changes, then history of patient, whether they have heart disease or not. Now coming to important cardiac marker. First one, cardiac troponin 1. Cardiac troponin 1, this one is the important marker used for bedside testing of samples, and it gives result immediately. That's why it is using point of care testing or near patient testing. This one care testing important marker, cardiac troponin I. This one started after 4 hours of myocardial injury. It peaks 18 to 24 hours. After that, normal by 3 to 5 days after that myocardial injury. This one is the specific marker for acute myocardial infarction, but it is a non-enzymatic marker. It is a regulatory protein. It is specific and non-enzymatic marker. Second one is CKMP. It started rising 4 to 6 hours after that myocardial injury. Peak 18 to 24 hours. Return to normal 2 to 3 days. This one is specific but less as compared to troponin. It is a enzymatic marker. It is a enzymatic marker, earliest enzymatic marker. Third one is cardiac troponin T. It started rising after 6 hours of myocardial injury, which is peak at 24 to 48 hours. Then return to normal 10 to 14 days. This one is specific and non-enzymatic marker. Next marker, LDH1. It is the first isoenzyme of lactate dehydrogenase, specific for the heart, as the concentration of LDH2 is much more in the serum. But in patient with heart disease, the concentration of LDH1 is more as comparing to LDH2, starting rising when it started to rising 24 hours after started off that pain, peak in 48 hours, return to normal 10 to 14 days. It is specific but it late marker to diagnosis of myocardial infarction. Then SGOT or AST started rising after 24 hours, peak at 48 hours, and return to normals 5 to 7 days. This one is non-specific because the concentration of AST also increase in liver disease, and also it is the late marker. So these are important marker in patient acute myocardial infarctions. So these are important markers. We'll see the graphic representation of marker. This is the time, duration 6 hour, 12 hour, 24 hour, 2 days, 3 days, up to 14 days. This one is enzyme concentration. The earliest non-specific marker is myoglobin. So it started rising from 2 to 4 hours, peak at 6 hours, then return to normal 12 hours. Second one is cardiac troponin 1. This started from 4 hours, peak at 18 to 24 hours, return to normal 3 to 5 days. Then CKMP started 4 to 6 hours, peak 18 to 24 hours, then normal 2 to 3 days. 2 to 3 days. Next one is this cardiac troponin T. This one started 6 hours, peak 24 to 48 hours, After that, then normal 10 to 14 days. Then LDH1 24 hours started, 48 hours peak, and normal at 10 to 14 days. So these are graphic representation of cardiac marker. Coming to newer marker. Newer marker for diagnosis of acute myocardial infarction. First one is ischemia modified albumin, IMA. Ischemia modified albumin. Second one is choline esterase. Choline esterase increases in patient with acute myocardial infarction, highly sensitive. Third one is highly sensitive C reactive protein. It also help in assessment of future attack of myocardial infarction in patient with previously diagnosis patient with myocardial infarction, future risk for acute myocardial infarction. So third one is highly sensitive C reactive protein. This one used for future risk of acute myocardial infarction, helpful assessment of future acute myocardial infarction. Next one is highly sensitive cardiac troponin T. It is started rising 3 hours after that attack. Then myeloperoxidase, then pregnancy associated plasma protein A, then last one is natriuretic peptide. These are the newer marker used for that acute used for cardiac markers. Newer markers used for cardiac marker. Newer marker is ischemia modified albumin 2 ANP. Thanks for watching.